Welcome to OET Answers.
Occupational English Test. OET Answers Practice Test, Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Mrs. Cooper. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Cooper. It's nice to see you again. How are you feeling today?
Oh, not too bad, but I had a bit of a scare yesterday. I got stung by a bee in my garden.
I see. That can certainly be alarming. Were you able to treat it right away?
Yes, I managed to get the stinger out pretty quickly, and I applied some ice. It's still a bit swollen today, though.
That's a good start. Did you experience any other symptoms besides the swelling?
Well, I felt a sharp pain right after the sting, but after a few minutes my whole arm started itching and swelling. I took an antihistamine because I remember that's what you suggested last time, but I wasn't sure if I needed anything stronger.
It sounds like you handled it well. Itching and swelling are typical reactions to bee stings, especially if you're somewhat sensitive to them. Did you experience any trouble breathing, dizziness, or swelling in other parts of your body?
No, none of that, thankfully. But I was a bit anxious that something more serious might happen.
That's understandable. Bee stings can range from mild to severe, and it's important to monitor how your body reacts, especially in the first 30 minutes after the sting. Since you didn't have any trouble breathing or dizziness, it sounds like you had what we call a local allergic reaction, which is uncomfortable but not life-threatening.
Local allergic reaction? Is that different from an allergic reaction I've heard about with bee stings?
Yes, it is. A local reaction means the swelling and symptoms are limited to the area around the sting, like your arm in this case. It can be quite painful and swollen for a few days, but it won't spread or cause more serious problems. The more severe reaction you're thinking of is called anaphylaxis, which is when the body reacts strongly, often with symptoms like difficulty breathing, swelling of the throat, rapid heart rate, or a rash that spreads quickly.
That sounds scary. How do I know if I'm at risk for that?
People who have had a previous anaphylactic reaction are at higher risk of having one again. But, since you didn't experience any of those symptoms after this sting or previous stings, it doesn't sound like you have a severe bee sting allergy. However, it's always wise to be cautious. If you ever notice any symptoms like difficulty breathing, swelling of the face or throat, or if you feel dizzy, it's crucial to get medical help immediately.
I see. And what about this swelling? It seems bigger than last time I got stung.
Swelling from bee stings can vary from one instance to another, even if you've been stung before. The body's response can change based on the location of the sting or how much venom was injected. It's not unusual for the swelling to get worse for 24 to 48 hours before it starts to improve. Applying ice like you did, taking antihistamines, and keeping the area elevated if possible can help reduce the swelling.
I've been icing it on and off, but it still feels tender.
That's typical for a local reaction. You could also try applying a topical corticosteroid cream to help with the inflammation. Over-the-counter hydrocortisone should work well. Just be sure to watch for any signs of infection, such as increasing redness, warmth around the area, or pus.
Infection? How would that happen from a sting?
It's rare, but if the stinger wasn't removed cleanly, or if bacteria got into the area after the sting, there's a small chance of infection. You've already taken good steps to prevent that by removing the stinger quickly, but it's always a good idea to be aware of the signs. If it starts looking worse instead of better, we might need to consider antibiotics.
I'll keep an eye on it. Do I need to worry about future stings? Could they get worse each time?
That's a good question. In most cases, reactions to bee stings remain the same or even decrease with time. However, in rare cases, people can develop a more severe allergic reaction after multiple stings over the years. If you've never had a serious reaction before and haven't developed one this time, you're likely at low risk for anaphylaxis. Still, it's important to stay cautious and treat future stings just as you have this one.
Should I be carrying an EpiPen just in case?
For people with a history of severe allergic reactions, we recommend carrying an EpiPen, which can administer epinephrine in an emergency.
Extract 2, questions 13 to 24. You hear a doctor talking to a patient called Stuart Fury. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good afternoon, Mr. Fury. I'm Dr. Catherine, and I understand you've come in today because of some headaches. Can you tell me a bit more about what's been going on?
Hi, Dr. Catherine. Yeah, I've been having these really sharp headaches lately, especially when I eat or drink something cold, like ice cream or a cold drink. It's like this sudden pain right in my forehead.
I see. How long have you been experiencing these headaches?
I think it started about 2 months ago. It doesn't happen every time I eat something cold, but when it does, the pain is pretty intense.
And how would you describe the pain? Is it a dull ache, a sharp pain, or something else?
It's sharp, like someone's stabbing me in the head. But it only lasts for a few seconds, maybe 30 seconds tops, and then it goes away.
Okay, so the pain comes on suddenly and goes away quickly. Does the pain radiate anywhere, like to your temples or behind your eyes?
No. It stays mostly in the middle of my forehead, maybe a little towards the temples, but it's pretty localized.
Do you notice any other symptoms when this happens? Nausea, dizziness, or anything like that?
No, it's just the headache. It's weird because I'll be fine 1 minute, then I take a bite of ice cream and bam, there's the headache.
I understand. How frequently does this happen? Every time you eat or drink something cold?
No, not every time. I'd say it happens maybe once or twice a week, depending on how often I have cold things. I love ice cream, but I'm starting to avoid it because of this.
That makes sense. Let's talk a little bit about your health history. Have you had any other types of headaches before, like migraines or tension headaches?
No, I've never really had tension headaches before. I mean, I've had the occasional headache after a long day, but nothing like this.
Okay, and are you taking any medications right now, either for this or anything else?
No, nothing regularly. I might take an ibuprofen if I get a regular headache, but that's about it.
Got it. And when you get these cold-triggered headaches, do you notice any triggers apart from cold food or drinks? Maybe a certain time of day or if you're particularly stressed?
No, it's really just when I have something cold. It's almost instant. Like as soon as the cold hits my mouth, the pain starts.
Have you tried anything to relieve the pain when it happens? For example, drinking warm water or pressing on your forehead?
Not really. I just sort of wait it out because it doesn't last long. I did read somewhere online that pressing your tongue against the roof of your mouth might help, but I haven't noticed much difference.
That's a good technique to try. The idea is that warming up the roof of your mouth, or palate, can help ease the headache faster. What you're describing sounds like something we call cold stimulus headache, or more commonly an ice cream headache. It's actually pretty common, though it can definitely be unpleasant.
Yeah, I've heard of that term before, ice cream headache. Is it serious though? Should I be worried?
No, ice cream headaches aren't typically a sign of anything serious. They happen when something cold touches the roof of your mouth or back of your throat. This causes the blood vessels in the area to constrict quickly, which sends pain signals to your brain. It's harmless but can feel quite severe in the moment. The good news is that they don't last long, just like you've experienced.
That's a relief. I was starting to worry that something else might be going on, especially with how sudden and painful it is.
It's understandable to be concerned. However, based on what you've described, this sounds like a classic case of a cold-induced headache, and you're not alone in experiencing it. A lot of people get them when they eat ice cream, drink a cold beverage too fast, or even breathe in very cold air.
So, is there anything I can do to stop it from happening, apart from avoiding cold stuff?
There are a few things you can try to reduce the chances of getting one. First, you could try eating or drinking cold items more slowly, which can help prevent the cold from hitting the roof of your mouth all at once. Some people also find that warming up the roof of their mouth immediately, like pressing your tongue to the roof of your mouth as you mentioned, can help ease the pain more quickly. Drinking something warm right after can also help.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear an intern talking to a doctor. Now read the question.
Dr. Harrison, I have a question about the patient with the persistent joint pain. Shouldn't we be considering rheumatoid arthritis as a possible diagnosis?
Yes, it's a possibility, but there are some symptoms you should examine more thoroughly to differentiate between rheumatoid arthritis and osteoarthritis. For instance, rheumatoid arthritis typically involves joint inflammation, but in this case, the inflammation is mild. Also, osteoarthritis usually affects joints on one side of the body, whereas rheumatoid arthritis tends to affect both sides symmetrically. Have you noticed any patterns like that?
Oh yes, I remember now. Rheumatoid arthritis is more likely to affect multiple small joints, like those in the hands and wrists, on both sides of the body. Thank you for helping me analyze the symptoms more carefully.
Now look at question 26. You hear part of a training on interprofessional collaboration in healthcare teams. Now read the question.
Collaboration across disciplines. One key aspect of this initiative is to establish regular interprofessional team meetings. These meetings will include doctors, nurses, pharmacists, and other allied health professionals, with the aim of creating a more integrated care approach. As many of you are aware, there has been a disconnect between different disciplines, which has sometimes led to miscommunication or delays in patient care. By encouraging more frequent and structured communication through these meetings, we hope to ensure that all team members are on the same page regarding patient treatment plans. This should lead to fewer treatment delays and more cohesive care plans that incorporate the expertise of all healthcare providers involved. We believe that through better interprofessional collaboration, we can ultimately improve patient outcomes and enhance the overall efficiency of care delivery in the hospital.
Now look at question 27. You hear a road safety officer talking to an accident investigator about a recent vehicle accident. Now, read the question.
The passenger was seated in the front seat when the accident happened. It looks like the car hit a tree after swerving off the road.
I see. Was the passenger wearing a seatbelt?
Yes, but the impact on the passenger's legs was significant. During the crash, the dashboard collapsed, trapping the passenger's right leg.
That could explain the severity of the leg injury.
Exactly. The seating position made it difficult for the passenger to brace for the impact, so the leg was exposed to more force. The leg's trapped position was the main cause of the injury.
Now look at question 28. You hear two doctors talking about a patient. Now read the question.
Hi, Dr. Miller. I wanted to discuss a patient with you. His blood sugar levels remain elevated despite being on maximum doses of oral medications.
Ah, I see. Is this the 58-year-old male with type 2 diabetes you've been treating for the past few years?
Yes, that's right. His latest HbA1c is 9.2%, and he's been on metformin and a sulfonylurea for over a year. Unfortunately, even with lifestyle modifications, his glucose levels are still high. I'm considering starting him on insulin as the next step.
I agree. Given the persistently elevated HbA1c despite oral medications, it sounds like the appropriate time to initiate insulin therapy. If oral agents aren't enough, insulin is typically the next step.
Now look at question 29. You hear two medical professionals talking to each other. Now read the question. Have you had a chance to look at the file for young Oliver, the 8-year-old boy who came in yesterday with concerns about his growth?
Yes, I did. He's the child referred for delayed growth, right? I noticed he's been falling off his growth curve for the past 2 years. His parents are quite worried.
Exactly. I wanted to get your input on whether we should be considering growth hormone testing at this stage.
I don't think his history points to a clear need for testing just yet. His family's short stature could be genetic. But one thing that caught my attention was his recent dietary changes. His parents mentioned he's been eating very poorly for the last year, which might be playing a major role in his delayed growth.
That makes sense. Did you notice anything else during your assessment?
Yes, his bone age was slightly delayed, which is expected in cases of nutritional growth delay. I've ordered some blood work to rule out underlying conditions, but at this point, addressing his nutrition seems like the priority.
Now look at question 30. You hear a physiotherapist talking to a patient. Now read the question.
Therapy exercises to further improve your mobility. I can see you've been working hard, and you're now able to put weight on your leg while using a crutch for support.
Yes, it's been a tough road since the accident. I'm getting better at walking on flat surfaces with the crutch, but inclines and uneven ground are still challenging.
What are your main concerns right now, Sam?
I really want to be able to walk up a slope without so much pain. When I try, I feel a lot of discomfort in my leg, especially around the knee. It's frustrating because I rely heavily on the crutch, and it makes me nervous that I might never walk independently again. Also, going up and down stairs is particularly hard, as I feel unstable.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For question 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Extract 1. Questions 31 to 36. You hear part of a training about interpreting chest X-rays for patients with respiratory issues. You now have 90 seconds to read questions.
Hello everyone, thank you for joining today's session on interpreting chest X-rays, particularly focusing on patients presenting with suspected pneumonia or pulmonary embolism. This training is designed for trainee R&A physicians, as you will often be the ones ordering initial imaging and interpreting results alongside radiologists. Chest X-rays are one of the most frequently used diagnostic tools in the emergency department, so understanding the basics of interpretation is crucial for effective decision-making. The topic for today is recognizing key features on chest X-rays that suggest pneumonia, pulmonary embolism, or other thoracic emergencies. We'll also discuss some proper imaging techniques and differentiate between various lung conditions. First, let's begin with pneumonia. On a chest X-ray, pneumonia often appears as a region of increased opacity, essentially, a whitish area on the film, which could represent fluid-filled alveoli. This might appear in one lobe of the lung, lobar pneumonia, or spread throughout multiple lobes, bronchopneumonia. Identifying the pattern is important for narrowing down possible causes. It's also useful to compare the left and right lungs for asymmetry, which could help in identifying unilateral consolidations commonly seen in pneumonia. When looking for pneumonia, we should also focus on any signs of air bronchograms. Air bronchograms are dark lines within an area of opacity and indicate that the surrounding alveoli are filled with fluid, which is typical in pneumonia. While interpreting these findings, make sure you assess for additional features like pleural effusion, which may suggest a complication such as emphysema. Now, let's move on to pulmonary embolism. Diagnosing pulmonary embolism solely on a chest X-ray can be challenging. However, X-rays can show indirect signs that might prompt further imaging. For example, a wedge-shaped area of increased opacity near the pleura, called Hampton's hump, might be indicative of a pulmonary infarction due to embolism. Another sign to look for is oligemia, which is reduced blood flow seen in the affected part of the lung, known as Westermarck's sign. A normal chest X-ray, particularly when accompanied by acute symptoms such as chest pain and dyspnea, could also be concerning for pulmonary embolism. In cases like this, you may need to consider ordering additional imaging, like a CT pulmonary angiogram, which is the gold standard for directly visualizing emboli within the pulmonary arteries. Apart from pneumonia and pulmonary embolism, We should also be aware of other thoracic emergencies that may be apparent on chest X-rays. Pneumothorax is a good example. Look for the absence of lung markings and a visible pleural line that's detached from the chest wall, indicating air between the lung and chest wall. Prompt identification is critical, because a large or tension pneumothorax might require immediate intervention. It's also essential to evaluate the mediastinum. A widened mediastinum could be indicative of serious conditions like aortic dissection, particularly in patients presenting with chest pain. When evaluating chest X-rays, it's important to follow a systematic approach, moving from general to specific features, so that no abnormalities are missed. Always start by ensuring the image quality, rotation, inspiration, exposure, and then proceed to examine the lung fields, pleura, mediastinum, diaphragm, and bones. The decision to order a chest X-ray often depends on clinical judgment. In patients presenting with respiratory symptoms, a thorough history and physical examination help determine if imaging is necessary. Generally, a chest X-ray is warranted when there is a suspicion of conditions such as pneumonia, pneumothorax, pulmonary embolism, or other pathologies that require immediate attention. For example, if a patient presents with fever, productive cough, and pleuritic chest pain, a chest X-ray is indicated to check for pneumonia or pleural effusion. However, a chest X-ray might not always be necessary in cases of mild, uncomplicated upper respiratory symptoms. Most viral respiratory infections can be diagnosed clinically without imaging. On the other hand, if a patient presents with chest pain, shortness of breath, or signs of hypoxia, it's crucial to order an X-ray to rule out conditions like pulmonary embolism or pneumothorax.
Extract 2. Questions 37 to 42. You hear an interview with a healthcare policy expert called Dr. Samuel Parker discussing an article about the impact of health insurance policies. Now, read the questions. You now have 90 seconds to read questions. Health insurance has become one of the most critical factors in determining whether or not patients can access necessary treatments. But how do different insurance models affect that access, and how can policy changes improve the situation? I'm Maya Cruz, and today my guest is Dr. Samuel Parker, co-author of a recent article examining the impact of health insurance policies on healthcare access and equity. Dr. Parker, thank you for joining us. Could you start by explaining how various health insurance models impact patient access to care?
Absolutely, Maya. When we talk about health insurance models, we're primarily looking at public programs like Medicare and Medicaid, private employer-based insurance, and the individual insurance market. Each of these models has its own set of rules, and those rules can either enhance or limit access to care. For example, public programs like Medicaid are designed to cover low-income populations, but they often come with limitations in terms of which providers patients can see or what treatments are covered. On the other hand, Employer-based insurance usually offers more comprehensive coverage, but not everyone has access to this type of insurance, especially those in lower-wage jobs or the self-employed.
I see. So, would you say that patients with private insurance have better access to care than those with public insurance?
In many cases, yes. Patients with private insurance often have fewer barriers to accessing care, but it's not always that simple. Even with private insurance, high deductibles, co-pays, and out-of-network costs can still prevent people from seeking necessary treatments. Public insurance can sometimes be more restrictive in terms of provider networks, but it's often more affordable, which is crucial for many families. The key issue is that access to care isn't just about having insurance, it's about the type of insurance you have and the terms of that coverage.
That makes sense. Your article also talks about disparities in health insurance coverage. Could you explain how these disparities manifest and which demographic groups are most affected?
Sure. Disparities in health insurance coverage are influenced by factors like income, race, ethnicity, and geographic location. For instance, minority populations, particularly Black and Hispanic individuals, are more likely to be uninsured or underinsured compared to their white counterparts. This is largely due to systemic issues like income inequality and employment patterns. Many minorities work in jobs that don't offer employer-sponsored health insurance, and they may not qualify for Medicaid or other public programs due to varying state eligibility requirements. The result is that these groups often face significant barriers to accessing necessary care, exacerbating health disparities.
So, you're saying that these disparities in coverage lead to worse health outcomes for certain groups?
Exactly. When people can't afford or don't have access to health insurance, they are more likely to delay or forego treatment, leading to worse outcomes over time. This is particularly evident in chronic conditions like diabetes, heart disease, and hypertension, which disproportionately affect minority populations. Without consistent access to care, these conditions often go unmanaged, leading to more severe health complications and higher mortality rates.
What policy changes do you think could improve access to care, particularly for underserved populations?
There are few potential policy changes that could make a significant difference. Expanding Medicaid eligibility in all states would be a good start. Currently, several states haven't adopted Medicaid expansion under the Affordable Care Act, which leaves millions of people without coverage. Another important change would be to introduce caps on out-of-pocket costs for private insurance plans, making care more affordable for those with high deductible plans. Additionally, we need policies that incentivize providers to offer more services in underserved areas, particularly rural regions where access to care is often limited.
Interesting. What about the role of the government versus the private sector? How do you see that balance affecting healthcare access in the future?
I think there's room for both the government and the private sector to contribute to improving access to care. The government can play a significant role in ensuring that basic healthcare services are accessible to all through public programs and regulation. At the same time, the private sector can drive innovation in care delivery models, like telehealth, which has the potential to expand access, particularly in rural and underserved areas. The challenge is finding the right balance between regulation and innovation, so we can address the gaps in the current system without stifling the development of new solutions.
That's a great point. Could you expand on how telehealth might change the landscape of healthcare access in the future?
Telehealth is already making a big impact, especially during the COVID-19 pandemic, where we saw a dramatic increase in its use. By allowing patients to connect with providers remotely, telehealth can overcome barriers like transportation, time off work, or the distance to the nearest healthcare facility. This is particularly beneficial for rural communities, where there might not be a local specialist available. However, for telehealth to truly be transformative, we need to ensure that everyone has access to the necessary technology and broadband internet, which is currently a barrier for some low-income and rural populations.
It sounds like telehealth has a lot of potential, but also some challenges. What steps could be taken to make telehealth more accessible to all patients?
One of the key steps is expanding broadband access to rural and underserved areas. Without a reliable internet connection, telehealth is simply not an option. Additionally, healthcare providers need to be incentivized to offer telehealth services, and insurance companies should provide comprehensive coverage for these services, including reimbursement at parity with in-person visits. Education is also crucial, Patients need to be aware that telehealth is a viable option and feel comfortable using it.
That's a lot of food for thought. Thank you, Dr. Parker, for your insights on this critical issue. It's clear that improving access to healthcare requires a multifaceted approach that addresses both policy and technology.
That is the end of Part C. You now have 2 minutes to check your answers.